So now I've spent quite a bit of time optimizing my plan, or you will have spent quite a bit of time optimizing your plan, should I say. I'm then going to have a look at evaluating it. So I know that I've not spent as much time as I could have on this, so this isn't, I'm expecting this not to be a clinically acceptable plan. And let's see. Okay, so the first thing I would do is visually work my way up and down, and I would use that to determine my coverage and whether there's hot spots anywhere. So I don't think there's any hot spots, but I can see that it's undercovering here, okay, in particular, and it's quite baggy in places. So I wouldn't accept this as a plan. It's something I would spend some more time at. But if you remember, we want to be able to quantify this plan as well in terms of the dose distribution and our tolerances. And the way we're going to do that is with a DVH. So I'm going to right click on here and I'm going to go show dose volume histogram. And we can tick our various structures on here. Okay, so first thing I'm going to do is pop my PTV on. I'm going to make that bigger. And actually that doesn't look too bad as a PTV, does it? Can you see there that we've got quite a steep drop off there? And if I load up my protocol, let's see what my protocol says. It says my D98 is greater than 95 and my D2 is 105. So we want between 95 and 105. Now, one thing I've just realised that we've not done, and why there's no numbers on here, is because we've not assigned the plan a dose yet, and that's what we need to do before it can obviously calculate the dose. So we need to calculate, or tell it the dose fractionation. So if I click that tab down here, across here, dose prescription, and my dose per fraction is 2.054, and we're doing 37 fractions. And there we go, we've got some dose on our DVH now. Right then, so let's have a look to see if we're meeting our parameters. So I said my D98 should be 95% of the dose. So dose to the structure is 98. So I'm going to right click on my crosshair, and D98 is up here, across here somewhere, and if I left click, so I left click and hold the left mouse key down like this and just slide up and down until I get 98. About there. Spend a bit more time getting that right. And you can see we're literally just in tolerance there. I personally, if this was a clinical plan, would spend a bit more time doing that. And our D2 was less than 105, so D2's down here somewhere. So let's work our way across here. And actually, I know that that's going to be in because I could see that from the plan. So that's okay. So D98 is just about in tolerance. So we're just about covering the PTV with 95%. But actually, I think we could make that quite a bit better. So let's go back to our dose statistics on here, and now I'm going to have a look at my rectum. And if I bring up my protocol again, this is the thing I'm interested in here again, isn't it? V40 less than 70, V50 less than 60, etc, etc, etc. So let's have a look at that. So the first one was, and again I'm not going to look through all of these in the video, but just to refresh your memory on how to do it. So V40 less than 70, so I've got my dose in grey up here. What you could do, if you find it easier, is you can go to there and click absolute dose, and that just flips the two around, so it's both exactly the same. So V40 here on my crosshair, and it wants to be less than 70%, and you can see that it's just about less than 70%. V50 less than 60, I can see that it is. I'm going to skip a few, and V74 less than 3%. So V74 is over here, and you can see we're well over that one. Okay, so that's gonna again, we could maybe look to optimize that, check that our coverage is nice and tight in the posterior border, but actually we might not be able to achieve that using 3D conformal planning, which is part of the reason for doing it as we are with this patient. And then again, I could click on my bladder and work my way through the bladder, so I'm not going to show you how to do that. So what I would do for each of those is write them down, and if you think you can make them better, which you probably can the first couple of times, is go back and make them better. If you've spent quite a bit of time optimizing your plan and this is as good as it's going to get, then save this plan And we're now going to have a go at planning the patient using IMRT and see what the differences are.